eliminating the burden of cancer. So the goal is really to get people from across the state, whether it be cancer professionals, from physicians to nurses to social workers to navigators to anyone working on cancer, primary care offices, patients, or just anyone interested, but really get everyone together and have that platform to talk about and work on cancer. Different task forces within the coalition from the different areas of cancer, such as colorectal and lung cancer. We have like a family history that looks at genetics. It also includes breast and ovarian cancer. We have a navigation, skin cancer task force, HPV, and then survivorship and palliative care task force. There are also work groups on community education, provider education, a work group working on policy, and a newly forming work group on financial toxicity. If anyone's really interested in digging into financial toxicity, please reach out to me and let me know. And then just really quick, if any interest in getting involved in the coalition, we really need everyone to be involved in this organization. You can sign up to get the newsletter and updates. It's just the coloradocancercoalition.org. You can join a task force. You can just listen into task force meetings on topics of interest. We have quarterly meetings that try to bring everyone together across the state. And then we have a calendar that shares different events and resources. So support groups or anything, cancer centers or anything anyone is doing, and it's an opportunity and a place for you all to share your information as well. And then we have a state cancer plan that we are in the works of revising starting in 2021. On that, we will be recording this webinar, so if y'all need to get back in and access it, you can access it on the Colorado Cancer Coalition page. And then I will turn it over to Jen to do a quick introduction to Jason and Laura, our presenters.
All right. Laura Nelson and Jason Engelhart are health law attorneys at Stinson LLP. Laura represents hospital systems, physician groups, and other healthcare providers. She advises on a wide range of fraud and abuse matters, including the Anti-Kickback Statute and Stark Law. She also assists healthcare providers with licensure, tax-exempt organization, and general business matters. Jason advises companies in the healthcare industry on a wide range of regulatory issues shaping the next generation of healthcare. He has a deep experience advising on fraud and abuse issues, including the Federal Anti-Kickback Statute.
And just to confirm, Jason and Laura, are your slides showing up on the screen?
They are not showing up on our screen, so we were wondering if maybe you could circulate them after the call to the invite list.
Yep, they should. Maybe we're just not in the present mode. They should be pulling up. Give me 1 second. I apologize.
Yeah, I saw your screen earlier, but now it's the little camera with a flash through it.
Okay, how about now?
I see something that says, oh my gosh, there it is, beautiful.
Maybe we can just view show then?
Yeah, no, I can see it, yeah. Okay, so title of our presentation is Avoiding Regulatory Road Rage. If you think that's super corny, then you can be confident that I'm the one responsible for that, and everything good about this presentation Laura's responsible for. So we'll kind of dive into the next slide and just give you a little overview of what we're going to be talking about. So in the next slide.
Hold on 1 second. It's not changing. I don't know what's going on with her. There. Sorry, guys.
Okay, perfect. So the local transportation safe harbor is a safe harbor to the Anti-Kickback Statute. So we're going to talk about what that is. We're going to talk about the safe harbor itself, and then some additional guidance on transportation services where, you know, the government has come up with these situations that have said they're not necessarily safe harbored, but we think that they're kind of technical, non-abusive violations of the anti-kickback statute and are therefore tolerated. So if we could just skip a couple slides ahead. So the anti-kickback statute, that is the 800-pound gorilla that we're dealing with here. And the elements of it are on the screen. So anti-kickback violation is the knowing and willful offer, payment, or solicitation or receipt of remuneration in cash or in kind to induce someone to make a referral for an item or service paid by a federal healthcare program. So, you know, absent the safe harbor, one could make the argument that giving transportation services to a patient is remuneration in kind that is intended to induce them to self-refer to your facility for treatment that is covered by a federal healthcare program. So that's why the statute is kind of potentially implicated by these types of arrangements. So the next slide. So fortunately, there are safe harbors to the anti-kickback statute. Like I said, it's very, very broad. It applies to anything seen as a kickback, bribe, rebate, in-kind, direct, indirect, any sort of remuneration. Applies to anyone, even to patients. It's, you know, often associated with pharma companies giving, you know, steak dinners to physicians to try to get them to prescribe their drugs, but the government applies it very, very broadly. And even if you have a proper purpose, so even if your purpose is to assure the kind of clinical efficacy of the treatment, making sure that folks get to their appointments, the vast majority of federal courts say if even one purpose of the arrangement is to induce referrals, it's illegal, and then it really should say absent a safe harbor. So on the next slide, like I said, there are safe harbors to the anti-kickback statute. There's also case law that kind of outlines what courts have said is and isn't okay under the anti-kickback statute. And then there are those advisory opinions that I talked about that the HHS, Office of Inspector General, puts out. They are theoretically very narrow and are only intended to apply to the party that submitted it, but it's very common for providers to rely on the OIG advisory opinions in sort of making risk-based decisions on kind of patient support and other types of activities. And then there's also these special fraud alerts and special advisory bulletins that the OIG occasionally issues as well. So on the next slide, so you might be thinking, what's the big deal? We're talking about this really in the abstract. How can my organization be affected by it? Well, here are the types of penalties that can be levied under the anti-kickback statute. Criminal prosecutions are fairly rare, but you know, fines and imprisonment, like any criminal violation, are a possibility. And then the vast majority of anti-kickback cases that the government pursues are civil. There are large monetary fines, 3 times the amount of the fees that are generated out of the kickback, plus per claim civil monetary penalties. And then the really big deal is that first bullet point there, exclusion. So that's sometimes referred to as the death sentence, because if a provider is excluded, that means, you know, no payment for Medicare or Medicaid. And as you all know, it's very difficult to be in the healthcare business if you can't do business with the government. So all that's to say, this is important, and there was a lot of ambiguity about this before the first OIG advisory opinions on local transportation came out, and certainly the ambiguity has been reduced by this local transportation safe harbor, which Laura is going to talk about.
So the local transportation safe harbor was promulgated a few years ago, and it's available pretty broadly to, advanced slide please. Available pretty broadly to any individual or entity, except for entities that primarily supply DME, pharmaceuticals, and other sort of supplies. So the purpose of the safe harbor is really to promote access to care, to get patients to doctors and facilities that they need to see when they need to see them, to make sure that they can stay on track with their treatment, access specialists, those types of things that can be barriers to good outcomes. So next slide. So there's two different types of transportation that are protected under the safe harbor. And the first is sort of point-to-point transportation offered directly to beneficiaries. So this is where a ride goes out, picks up the patient, brings them to the facility, and then takes them home again. The other one, which I'm going to talk about in a little bit, is a shuttle service, which runs on a fixed route and picks patients up and drops them off at certain predefined points in the community. So going back to the transportation directly for beneficiaries, there's a number of criteria that the transportation service that you or your facility provides has to satisfy to meet the safe harbor. And the first is that the transportation, the availability of the transportation must be set forth in a uniformly and consistently applied policy. And what this is designed to prevent is providers from cherry-picking patients to provide transportation to based on things like who is their insurance company. We only are going to provide transportation to patients who have high reimbursement rates for this particular procedure. Or we're only going to provide transportation to patients who are high utilizers, generate above a certain amount in fees, things like that. It really should be focused on providing transportation to those patients who need it the most. Going along with that, provision of the transportation can't be related to past or anticipated volume or value of federal health care program business. So again, this is getting at, you can't target it at sort of certain patients who are receiving, high reimbursement services in hopes of keeping them coming back to your facility to get those services. Transportation here, we're talking about, run-of-the-mill rides. It's not air transportation, no luxury vehicles, no stretch Hummers. And we're also not talking about ambulance-level transportation here. That would be covered separately. This is just, somebody needs a ride to get to and from the appointment. And then transportation also cannot be publicly marketed or advertised. And this is a little bit tricky because on one hand, you want the people who need these services to be aware that they exist. But what you can't do is go out and say, come to our facility over somebody else because we're going to transport you here. We're going to offer these transportation services. So it's really not using it in sort of your PR type materials. Next slide, please. So then when the transportation itself is occurring, you have the patients that they're kind of a captive audience, right? So that would be a great time to tell them about all of the wonderful services your facility can offer. Well, the government has thought of that and does not allow any sort of marketing of healthcare items or services during the transportation or at any time by the drivers who provide the transportation. So the driver can't hand the patient a brochure when they get in the car or when they get out of the car. The driver just needs to pick them up, drive them to the appointment, and then take them home again with no marketing involved. And then the other thing is that drivers, or if you contract with the transportation services, can't be paid on a per beneficiary transported basis. So there's no incentive to sort of offer as much transportation as you can to increase payment. And then this last one kind of goes along with the marketing issue I mentioned earlier, which is you can only make the free or discounted transportation available to established patients. And the government describes an established patient as a person who has selected and initiated contact to schedule an appointment or who has previously attended an appointment with the provider. And so here's where your staff has to be a little bit savvy in terms of, trying to figure out which patients may need transportation based on their past patterns of potentially missing appointments or things like that, or if they express concern about transportation when they call to schedule the appointment, that's kind of the appropriate time to make that referral over to the social worker or whoever is going to arrange the service for them. But again, you can't sort of go out and affirmatively recruit people to take advantage of these transportation services. Then next slide. There's also some distance and purpose limitations. So currently, the distance limitations for the transportation are transportation of no more than 25 miles one way between the beneficiary's pickup point and the healthcare provider in urban areas and 50 miles in rural areas. And this is really designed to not allow facilities to expand their service area beyond what it would typically be. You're not going to go out 200 miles and get a patient, bring them to your facility when there's a facility that they could go to maybe 10 miles down the street from them. It's really focused on just helping patients in your service area access treatment. And then along with that, the purpose of the transportation has to be to obtain medically necessary items and services. And finally, this is the government's favorite thing to include in every safe harbor. You can't shift the cost of free or discounted transportation services onto any federal health care program, other payers, or other individuals. So this would have to be an administrative cost that the provider just eats as part of their normal operations. And where this can be particularly tricky is if you are operating a rural health clinic or a critical access hospital or another facility that gets cost-based reimbursement. You're going to have to be particularly careful here to make sure you're only including includable costs on your cost report and not anything having to do with the free transportation. So next slide, we'll talk about the shuttle services a little bit. Very similar requirements, but just modified slightly to reflect a different type of transportation. Again, we're talking about just, regular vehicles here, no air, luxury, or ambulance level transportation. No marketing or advertising except for what's necessary to post a shuttle route and scheduling details. Again, no marketing of healthcare items or services to your captive audience in the shuttle. And same thing with the driver or other transportation service not being paid on a per beneficiary transported basis. Next slide. Similar distance requirements as well. No more than 25 miles, 50 miles in rural areas from any stop on the route to any stop at a location where healthcare items or services are provided. And again, costs have to be treated as an administrative expense and not passed on to any federal healthcare program, other payer, or individual. Next slide. And one more, please. So recently, there's been some proposed changes to the local transportation safe harbor based on comments that the government's received after people have worked with it for a couple of years. So I just want to caution that these are proposed changes. These are not final rules yet. They can't be relied upon. They would not be a defense in any sort of enforcement action, but it gives you an idea of where the government's thinking is going on this issue. And I'd encourage you to watch for these regulations to be finalized and any changes that might occur during the finalization. So the proposals right now are to expand that mileage limit for rural areas from 50 miles to 75 miles. And if any of you work at rural facilities or work with rural facilities, you know that patients in rural areas often have to travel exceptionally long distances to get particularly specialist care, and that transportation can be a real barrier there. So I think that this will really help patients in rural areas get better access to transportation. Additionally, there's discussion of removing the mileage limit for patients after being discharged from a healthcare facility after inpatient admission. And where this can be particularly useful is if a patient received, for example, emergency ambulance or air transportation to a facility a considerable distance from their home for sort of specialized care, allowing the facility to transport them back home and kind of complete that circuit. The OIG is also considering sort of a number of variations of that, including, right now it's only inpatient admission and discharge. They're also talking about emergency department, observation, ASC, other types of facilities that a patient might be discharged from, and also protecting transportation to locations other than a patient's residence. So those are some changes to watch for. Next slide. And the other big thing that's potentially coming down the pike is, you'll recall earlier I said, right now transportation is only authorized for medically necessary items and services, but those of you who work in the healthcare industry, you know that there are a lot of social determinants for health that impact outcomes to a considerable degree. So one thing that OIG is considering is allowing that transportation to expand a little bit to include other things that are not medical but might improve or maintain the patient's health, such as food banks, social service facilities, affordable housing facilities, health clubs, exercise facilities, or support groups and things of that nature. So be watching for that if that's something that your facility is interested in doing.
Alrighty, so I will wrap up the presentation with some additional guidance on transportation. And, these are, if we go to the next slide, they're largely OIG advisory opinions So this would be something that you turn to make kind of a risk determination if your has some sort of a transportation arrangement that doesn't fit squarely within the safe harbor. And I'd say if you don't have something that fits squarely within the safe harbor, I would, strongly encourage you to consult with your legal and/or compliance departments, and they will, in all likelihood, look to OIG advisory opinions like the ones that we're going to talk about here briefly. So previous factors that the government has said are helpful in rendering a transportation arrangement non-abusive are, one, if it's related to special needs or kind of a specialized prescribed treatment regimen. So very, frail populations, the elderly, women in high-risk pregnancies, children participating in clinical trials, experimental treatments. Like the safe harbor, the OIG has said, modest transportation is viewed much more favorably than, kind of luxury transportation, and making it available really in limited circumstances where the patient has said, hey, I'm having trouble getting to appointments. That's another factor that's looked upon favorably. So on the next slide. And again, so these advisory opinions were part of what the OIG looked to when they were promulgating the safe harbor. So, the non-advertising, only offering it to existing patients, those are also going to be helpful factors, even if you don't fit within the safe harbor exactly. Making sure that eligibility is determined based on a written policy and not based on, how valuable the patient's going to be to you or whether there's federal reimbursement available for that patient's course of treatment. And then, also limiting it to local areas. So if you are a, kind of a destination medical center that's offering free transportation to out-of-state patients, that's going to be looked upon with a lot greater scrutiny than if you are a provider that's transporting someone 10 or 15 miles because they have transportation challenges in their lives. And a couple other factors on the next slide that we'll look to. Again, not shifting any of these to government programs as bad debt, and then it's viewed much more favorably if the healthcare provider's nonprofit, governmental or research charitable organization. And to assist you in talking to your compliance folks, legal folks, we've got the citations to the OIG advisory opinions that we've discussed in here so that they can line up the facts of your arrangement with the available guidance. So that is our presentation, and we are happy to take any questions you might have. And on the last slide, we've got our our lovely, relatively new photos and contact information. So if you don't want to ask a question now, obviously feel free to reach out to us.
So if anyone has any questions, maybe go ahead and take yourself off mute, and you can ask the presenter your questions.
All right, well, thank you very much for having us today. It was a pleasure to speak with you, and like Jason said, our contact information is in the slide deck, so if you have any questions that come up in the future, we'd be happy to work with you.
Thank you, Jason and Laura. We really appreciate your time and your expertise in sharing the system and the complexity of it. I think is really valuable to come out of it knowing that it is a right to provide transportation to our patients, and just that there are some restrictions within that. And that and I think it helps our mobility managers in Colorado understand and maybe develop some partnerships with some of their local healthcare facilities, seeing how they can benefit one another moving forward. So again, we really appreciate your time and your information. I'm going to go on to the next slide that highlights some of our transportation resources in the state of Colorado. just for those people who may not be aware of them, so CASTA is like a state transportation agency that collects a lot of resources, and they do some advocacy work in the transportation world. So if you went to their website, look up CASTA as an abbreviation, they do have a transit directory, and they also have a Colorado Transit Resource Library. And then the Department of Transportation has Bustang, which is really affordable bus system that is growing within our state. So if you have patients in rural areas that need to come into the Denver, that could be a really good transportation resource to share with those patients. And then in the Denver metro area, we have a regional mobility access council, and they go by Dr. Mac for short, but they have this resource guide called the Getting There Guide, and that highlights a lot of different transportation resources, and it's free on their website, so you would just need to Google Dr. Mac Getting There Guide, or reach out to Jen or I. We're happy to help you with some of those resources. And then if you're in an area that we haven't highlighted, reaching out to your local county authorities is a great way to learn about what transportation options are in your community. And if you have any additional questions, again, like I would be happy to help you in that specific area.
Yeah.
Could you please take a look? Could you please take a look at the group chat?
Can we?
Yep. We're going to stop sharing for a minute just to get on the chat. Here we go. So the first question is, can we share or send out the slide deck? Laura and Jason, are you okay with us sharing the slide deck?
They might have signed off. I'll check with them, but I think that they're pretty positive. They're okay with that. Joan asked that question.
For the other questions, we will send those to the presenters. It looks like we did lose them, and then make sure that you'll all get the responses. So if you have any last questions, please type those in the chat box. Otherwise, thank you all for attending today.
What does CCA, do you know what that stands for? What does, Janet, what does CCCA stand for?
Oh, Cancer Center Treatments of America. When they come to the rural communities, they fly the people to another state. How does that happen?
Okay.
All right, I don't know how that happens. So we'll work with our presenters and see if we can find an answer for you, Janet. And then we'll send out an email